Hi, my name is Remy Perry, and I represent Caregivers on the Board of Directors of the Brain Injury Association of York Region. All of that began a little over 9 years ago, and my wife and I were involved in a pretty severe car accident that left her with post-concussion syndrome. And I'll tell you, when we first realized that my wife's injury was going to be around for a long while, we had no idea who to turn to. We thought just the family doctor. Fortunately, our lawyer was able to connect us with one of the most crucial members of the rehab team, an occupational therapist. We had two over those first few years, and we were shocked and grateful with how much of an impact that they had on the long road that we took to rehabilitation. In fact, it was our first OT that put us in touch with Briar, which has led to so many positive changes in our lives. Today, I have the privilege of talking with three OTs about how they work with brain injury survivors and their caregivers to make that rehabilitation possible. I'm speaking with Faith Gallant. She is an occupational therapist for NCCO Rehabilitation Services and Omega Medical Associates. She's been an OT for over 5 years and has a background in neuroscience and mental health. Welcome, Faith.
Thank you so much for having me. I'm excited to be here.
I'm also talking with Taz Lalani, founder and owner of Focus on Function. She has operated her private practice since 2004 and also practices as a health consultant, currently with Abilities Rehabilitation in the North as Director of Pediatrics. Welcome also, Taz.
Thank you, Remy. It is a pleasure to be on your podcast. And I might just say you left us for last. This is the last one of your season. So congratulations.
The best for last, the best for last. So I'd like to start off by diving in with both feet. I had to learn what an occupational therapist does by needing one, or at least my wife needing one. What I learned from them was immense. Probably the most important question we had were, what are the most common cognitive and behavioral changes that you see in patients with brain injuries? I'll start with you, Taz.
So you started with a loaded question, so I'm going to do my best to answer it. Faith knows what I'm talking about when I say that. When you say common, it's interesting because over the years, I would say that when I ask people, what trouble are you having? And I usually say thinking, because cognitive is not always the most best known term. And I don't think we need to use terms and lingos when we're starting to work with a family, because that also is very intimidating when everyone else is talking to them in different ways. And so I usually try to come to them with user-friendly terms and reduce the lingo. But when I ask them, memory and attention, I would say are probably most reported, but that's because I think they're the most understood. And everyone talks about their memory and attention, even if you don't have any issues. I talk about my memory, but the things that people don't talk about are the things that I actually start delving into, because we have something called executive functions that we all have to do. And that is the whole part of the brain that organizes everything. And those are the things that when you start delving into, you start to realize that those are the things that really start impacting people on a bigger scale. So that's the cognitive side to it. And the behavioral side, I would say, is mood. People talk about mood as being something behavioral that's changed. Also, social activities. And the other thing I'm thinking is motivation. That's a big thing. People often say to me, I just don't feel motivated. Sometimes people use the word lazy, and then we turn it around and say, you're not lazy. This is really your brain sort of telling you not to do something, feeling like you don't want to do it. So again, it's about changing that language, because everybody else might interpret it as them being lazy, but that's not what we want to start off the conversation with when we're talking about brain injury.
It's like their brain is protecting them, saying, this is too much for you. You're not going to be able to handle this. And they interpret it because you still, I think, as survivors and so even as caregivers, in terms of pre-injury, what would look like lazy before now looks like someone who's dealing with a brain injury.
That is absolutely true. And then the other side of it is something like depression, in fact, does not permit someone to be motivated. The actual definition of depression, depressed meaning you have a reduction in activity. you have a reduction in what you want to do. You don't feel like doing anything. So we talk about initiation. So it's also an education to the person and to the family that what they're seeing is in fact symptoms of brain injury. And that's important so that they don't feel like it's just the person doing it for themselves, but it actually is part of the injury.
So, Faith, do you find yourself educating both the caregivers and the survivors and on reinterpreting, like what Taz said, what they think of are negative symptoms, but are actually can be put in different ways, more positive?
Education is such a huge part of what we do as occupational therapists, and educating too a lot on the language that they're using. It's unfortunate, and you know what, I'm very guilty of it too, but using negative language to describe myself or what I did or didn't do this week or goals that I'm working on. And I think when individuals start to talk about themselves negatively, talk about what they're trying to achieve in terms of their barriers and what they can't do, and that's constantly what they're hearing themselves saying, that's another barrier for them. And so a lot of education and reframing on what their thoughts are, what their goals are, and what their beliefs are, and educating them. I like to take a really realistic approach, and we talk about SMART goals and setting goals that are realistic, but also being realistic about what the barriers are. So individuals have an appropriate idea of what to expect. So yes, I think you can't have OT without the education piece when it comes to setting and working on goals.
Now, I remember speaking with Rachel. She's a case manager, Rachel Greenwood, and she said it is a very difficult and a fine line. You have to be very careful that you remain positive, even discussing the limitations that you might see in a client that might impact how quickly their program goes and how you set those goals. Do you find that that's a very difficult initial consultation with them? Those are the first few initial conversations?
Of course, it is a very fine line. I agree with that. You want to be positive and you want to instill positive thinking in their own mindset, but I never want to be so positive that I set someone's expectations so high that people feel that they have failed in reaching a goal, because ultimately that doesn't feel too good either. And so the approach that I like to take is, I think a lot of individuals set goals in terms of getting back to their old self, but any individual going through life is never trying to be their old self. We are all individuals who are evolving. My goals for the next 5 years aren't to be what I looked like 2 years ago. It's going to be to look like a different person. And so that's what I try and tell others too. We're going to set goals and we're going to try and get you back to the activities that you enjoyed before, but they may look different. And that's okay because we're not trying to be who you were. We're evolving as humans do. We're evolving and moving forward, and that might look different, and that's okay.
Something I have learned over my years, and that's what caregivers have taught me, families have taught me, is the opposite, and it's actually to be more positive. So I've learned this lesson from two particular mothers over my careers. These mothers had both children with catastrophic or very serious injuries. One was actually in a coma, and everybody told this family that basically he's going to be left in a vegetative state. And she said to me, no, he's not. And I've learned something, and probably more so over the last 10 years, is that I say this often now, I bear no judgment. What they say to me, I bear no judgment. I'm going to say this, I am somebody who believes in God, but I am not somebody, and I don't believe that physicians are God. I don't believe nurses are God. I don't believe therapists are God. We are not here to tell people ultimately what's going to happen to their person. So the end thing that ended up happening with this young boy is that she went in every day. The mother and father went in every day, spent a whole bunch of time with him. And all of a sudden, one day, 6 months later, he woke up and looked at the father and said, get me the heck out of here. And he was in a somewhat of a long-term care home. Now, he couldn't speak properly, but he did whisper that, and enough so that they understood that all this time he had been listening to everybody's conversations, including everybody around him who was telling the parents that he would not be able to have any kind of function. This young man now is living with supports in a living assisted facility and enjoying his life. And so I always say this to people: never underestimate the power of people and family and love. Realistic optimism, I do believe in, but there are aspects in brain injury where we still don't understand the brain. I have to say this because it's humbled me over the years. And so when somebody says this to me, is my child ever going to do this? Because I work in pediatrics, is my mother ever going to do this? I often say, I don't know. But what do we need to work towards? Things might be different, they might look different, but what do we need to do to work towards a goal? And let's see how far we can get. And that's what I say.
We're talking about one of the most complex organs in the human body, the most complex, I guess, and the one about which we know the least. So, there's a famous book called The Brain That Heals Itself, and we still don't know how as far as I know. That's one of the things I've learned over the years, is that it's a very complex organism that sometimes is able to reroute and forge new paths and that type of thing. Now, when you do run up against caregivers that get quite depressed or quite negative, what do you say to them?
It's very challenging. As an occupational therapist, as any healthcare provider, it's difficult because you have to keep in mind who your client is, and the caregiver can be an extension of them, but you are not counseling or providing rehab to them. And you always have to remember that your role is to keep the best interest of your client or your patient at the forefront of what you do. So that's something that I'm always trying to remind myself when I'm interacting with a caregiver, which happens quite a bit. And if they happen to be in a negative space as well, another thing that I try and tell myself so I come at everything objectively is that the caregiver is also wanting what's best for the client or the patient, their loved one. They are reacting the way that they are because they want what's best for them. And they are likely working with multiple systems that they have maybe no experience with, multiple systems that are very difficult to navigate. They're seeing the sometimes suffering of their loved one. Who knows what other health challenges they have going on, other family dynamics they are going on. And so the negativity, I guess, for lack of a better term, that they may be expressing is a factor of all of these things. And so that's what I try and tell myself, to stay objective about the situation. And so I try and approach it with empathy for everything that I just discussed that they are going through, with education, with consent of the client or patient, involving them in sessions as much as I can, and being mindful of the language that I'm using, the positivity that I'm bringing to the session, and with the, again, consent of the individual that I'm working with, can I provide education and resources about how to support you, so it's still client-centered, to the caregiver. And I think in most times, as mentioned, we're not God. I often tell individuals, I don't have a magic wand. I wish I had a magic wand. That would be so much easier. I could fix everyone's problem in one session. We have the luxury of working with clients typically over a long period of time. And so I think the more I can involve a caregiver in the sessions and take the approach of slow and steady is how I've seen the most benefit or the most effect.
Do you find yourself sometimes pointing out progress that they may have missed, things that you see as a professional?
Absolutely. All the time, to clients and caregivers. In the moment, it's really difficult when you're not there, when you're not achieving what you want to achieve. It's really hard. I try and call back and say, remember when I first started working with you? Remember a few weeks ago when this was the thing that was really hard? Can we just pause and take a moment to see how it's so easy? You just blew right through that, no problem. And that was what we were struggling with 2 months ago. And here we are today. We're at a new barrier, but we're going to address this. But let's take a moment to acknowledge the really great thing you also just did. I think everyone, even myself, sometimes needs a reminder of that progress that's being made.
I just say I 100% agree with Faith on everything she just said. And I have to say that's the beauty with OT, is that each one of us are going to do things a little differently, but at the core of where it comes from, we all share the same philosophy. So Remy, you could put us all in a room and we're probably going to gravitate to each other and find each other, because oftentimes I think OTs just have, there's a perspective that we come with, that we're here to help you, but we're not here to tell you how. We're here to figure out with you, how are we going to do that, but how is it best for you? And how is it best for the family? How is it best for everybody? But I agree with Faith. She brings up a really good point. At the end of the day, the client is still our client. And we got to center on that, because as much as Remy, we want to say every caregiver has that person's best interest at heart. I've also seen a couple of situations where that's not the case. And those are also the situations where, as OTs, we have to be mindful of what's going on in the situation. And we have to be aware, is that person also able to voice their concerns if there's something else going on in a situation where they don't feel comfortable. And
you've actually seen situations where the caregiver has impeded the progress or perhaps hampered the progress because of either negative attitude or their own depression or some of the things that commonly afflict caregivers of brain injury survivors. Now,
Or if I can just add in one thing too, I think, and Taz, it sounds like maybe you're touching on the same thing here, but I always try and give a voice to the client first. Caregivers, all credit and kudos and love and support goes to the caregivers, because they are doing so much for their loved one. And like any human, sometimes when you get in a role of having to support, you are become really good at that role and you really try and stick to that role. And so sometimes during sessions, I find when I ask the client a question, a caregiver is really quick to provide that information or step in, which is so lovely, because again, it's coming from such a lovely place of love and support. But maybe it's not accurate. Maybe that's not what the client is wanting, or not what they had in mind, or not what they, or maybe they had something else to express. And so while I always appreciate that, sometimes I do try and say, can I just get a moment with the client? Can we just go on a walk together? You know what? You take a little bit, just sit on the couch, enjoy the next half hour. We're going to go on a walk together, so that I can try and just get that information direct from the source as well sometimes.
So they're overeager caregivers step in too
Yeah.
much. I have to admit, there are probably times in my wife's rehabilitation when I've been a little bit overeager to answer questions for her, especially when she had word recall difficulties. So it is difficult when your life becomes looking after a survivor to step back and realize that they need to speak for themselves. It's healthy for them to speak for themselves, and this is something that they have to do. So both of you specialize quite a bit in the occupational therapists involved in all sorts of different injuries and recoveries, but the both of you specialize in brain injuries in particular. Are there certain transitions that you tend to see that you can take into consideration when you're recommending future services?
Oh, you're very good again at asking loaded questions, isn't he, Faith?
Very much so.
So before I answer that question, I want to clarify something with brain injury, which is really important to do, because oftentimes with brain injury, we always think of head injuries and concussion, but there's a whole spectrum involved in brain injury. And I have had the benefit a few years ago of working in a neurological outpatient clinic with WSIB. And I started there when it was started, and I got to work with some really interesting neurologists. We saw such interesting cases, Remy, that honestly, I think differently about brain injury now. We always knew this. Faith and I learned this as part of our education, but brain injury is anything that is acquired after birth. Any kind of, we call it the insult that happens to the brain, or the injury that happens after birth. So you are talking brain cancer, right? You're talking tumors that might be malignant, might not be malignant. Then you're talking about anoxia. Someone has had lack of oxygen, whether they drowned, whether there was a choking, a suffocating, whatever it was. Then there could be viruses, meningitis. Then there could be COVID, for example, which is very interesting and has given us a lot of information about what viruses can do to the brain. And so I look at that whole spectrum. So when you ask me that question, I'm a very scientific, I like to research. So what I'm going to do is I'm going to say it's so dependent, it's like a fingerprint. It's dependent on who that person was, what's their history, when did they have the injury, because age really does matter as well. And also, what is it that they have? Because Remy, you could have somebody with brain cancer who now 5 years later has metastasis. And so the goals with that person, they might be palliative. The goals with that person might be very different than the 12-year-old I'm working with who has a concussion. And Faith and I, this is again, the beauty of OT is that we can change it up fast. We can adapt to the needs of that person. So I'm not avoiding your question, and Faith can add on, but there's such a spectrum of brain injury.
Faith, do you have anything to add to that?
Ditto. It's really dependent. The other thing I think relevant to add here is what's really dependent is the support, the familial, the social support they have in place. That is a huge factor. And when you're talking specifically about transitions and looking at where someone is going to thrive, where someone's going to be able to meet their goals, and where they actually qualify to go into placement into whatever facility or community that you're talking about, a huge factor is the family support. And do they have enough support to transition back home? Do we have to look at alternative options for support for them? So it's very individual specific and scenario specific.
And Faith is being polite. I forgot stroke. Faith is being very polite because
Yes.
I didn't say stroke and she didn't correct. But stroke, by the way, is another huge brain injury that people can relate to.
I think a lot of the time we think of traumatic brain injuries or something that's caused by a car accident or a motorcycle accident or a fall or something like that. But there's a lot of times it's the body initiating the brain injury. It's the brain itself. Do you find that there are certain strategies that help with your clients that you use a lot that help them regain independence in their daily tasks like bathing, eating, dressing, etc., that type of thing? Something that you keep going to? Or is that all over
these loaded questions? It's hard to say because I think thus far we've talked about brain injury and we've talked about cognition and we've talked about behavior, but physical limitations after a brain injury are huge as well. Things like balance, tremors, even just fatigue and stamina. And so you could have two individuals. They could be the same identified gender, they could be the same age, they could have the same diagnoses, and the physical, cognitive, and emotional challenges that those two individuals face can be drastically different. And even if they both have a goal of increasing independence with bathing, I may take two different approaches with those individuals. I have to determine what framework am I working within here? Is it more a biophysical framework? Am I looking at a psychiatric framework? And based on the framework that I'm approaching that individual with, then what are the aids? What are the remedial and compensatory strategies that we are going to use with that individual? And so even though they have the same diagnoses, the approach I could be taking with them are very different depending on their unique symptoms that they're experiencing that create their own unique barriers.
So that, for example, if you have a client that has trouble remembering something, which is very common in brain, regardless of the source, your approach to dealing with that in the home environment or wherever else, it can be quite different depending on a number of the factors that you mentioned.
Maybe for one individual, technology is really big for them and they have a lot of experience with technology. They love working with technology. And maybe that's an approach that we use, but maybe someone else, their screen tolerance is really poor and they don't jive well with using the technology. Maybe someone is really keen on using compensatory aids, so aids that take some of the load off of them. Maybe someone is embarrassed by compensatory aids and they really want to engage in strengthening their own specific memory. Maybe, again, people have caregiver or caregivers, multiple around that can help support them with their memory. And they want to use a physical calendar on their fridge or something like that. But maybe others are hiding their challenges from the individuals in the home that they're living with, and they don't want a physical calendar on display because that's going to bring more attention to their challenges. So there's just, again, I think the theme is going to be that there's so many unique factors in every case that we work with, and that's really going to change up our approach.
It's interesting listening to Faith because I taught OTAs and PTAs 3 or 4 years ago, and I had to go back, and exactly what she's saying is look at the approaches, because when you're teaching someone else, how do you look at the person? There has to be some kind of systematic approach. But I'm going to date myself here. So I've been working for 30 years, right? So back in the day, you know what we talked about, and I still use this a lot with families because it's easy to remember. The brain responds to routine. And the brain responds to practice, and it doesn't matter who you are. You can be an athlete, you could be a scientist, you could be a student. So Remy, I know you were a teacher, and we would say study, practice, repeat, routine, you get better. And the brain is no different. So taking the pieces that Faith is saying is how the choices are made of what strategies to apply. And then the bigger umbrella is to everybody, keep doing it. And the number one thing I say to families is don't change it up. What they were doing before, continue it after. Even rearranging a kitchen for somebody after having a brain injury is tremendously frustrating and confusing. So I used to very much have a problem when people were in hospital, and they used to have kitchens and apartments back in the day, and they used to have them in there and they would be doing assessments. And I'd be sitting there going, this kitchen, they don't know. And all of a sudden we'd see them in the community, we'd go home, and all of a sudden I'd say to them, can you make me a coffee? And they just go around and zip around their kitchen. And when I mean zip around, I mean cognitively fast and get everything that they could get. Because the beauty of the brain is once it's rote, we call it rote, it's stuck, embedded in your brain in a place that it cannot be touched usually. So
it's like riding a bike.
Correct. Yeah. So that's exactly the example I was just going to give, is riding a bike is going to become rote. So people have been doing something for years and years and years and years. And Remy, we often say I could do it with my eyes closed. That's exactly what we're talking about, is that it's become so familiar, so ingrained. The brain is actually no longer using higher level functions to actually do that task anymore. So a pilot who's been flying for 30 years, and I'm not saying this because I believe it, I don't want them to close their eyes, but you could probably get a really good pilot who could walk into the cockpit, he or she, and probably close their eyes and turn on switches. I hope they're flying with their eyes open, but you get what I'm saying. It becomes rote to some degree.
And it's funny you should say that, because I found as a teacher, I worked with children with autism, and it was the same thing, routine. You do not change the routine. One of the things that I also found extremely helpful for people with executive functioning disorders, in this case, autism, was visual. A lot of visuals. Do you find that the two of you in your practice that there's a high value placed in visual aids, things that remind people of the routine, at least until it becomes automatic?
It depends. I think Faith can answer that question. It depends. It depends on what the strengths are. She's nodding, but I'm going to let her talk to this because brain injury can affect different sensory systems. So Faith, take it over.
It depends. They can be great, and some people can thrive with visual cues, but you also see when you're setting up a visual cue at first, you see this big spike and it's really effective, but then it just becomes a part of your environment sometimes. And so you could have a sign that says turn off the lights when you're leaving the house. And every time you leave the house, the first few times you see the sign, you're like, oh, turn off the lights. It's a good reminder. But then it just becomes another sign on the wall that you're failing to see. So it really depends. And I'm forgetting, what was the second half of the question now?
Do you find that they help in transitioning to routine becoming automatic? Or do
Mhm.
you, a lot of it, I imagine, is getting to know and we talked about, we do this in teaching, we find the learning mode, whether that's auditory, whether that's visual. For a lot of people, it's visual, but not for everyone. Sometimes it's social, sometimes it's something else. And we find out how that works in our students, and we go with that particular student. Do you find it's the same thing? You really need to get to know your client. You find if
Yeah.
something works, and if it doesn't, if they're ignoring the sign on the wall, let's get rid of it. Let's try something else.
Well, Taz, I don't know about you, but it's funny. I find when I first start working with a client, I'm doing a lot of the learning about them, about what works for them. And I could have a strategy that has been so effective with 100 clients. And if I bring it to someone and it's not working for them based on their past experience, based on how their brain has always operated, I can push and push, but we're just going to keep running into that same wall. So you have to learn about your clients, you have to listen to that feedback, and you have to be able to adapt and be flexible and bring something new to the table. You
So,
any thoughts
you
on
know,
that, Taz?
yeah, and you know what, working with children, be this thing, I learn a lot, and I learn a lot working with children. So I'm also a sensory-based trained OT. Being a sensory trained OT has taught me also that the more you do, the more senses you use, the
Mm,
more you learn. And that is something also I think the best teachers, Remy, have included in their lesson
I
plans
was about
because
to say.
traditionally, back in the day, I had teachers who actually took us outside when they wanted
mhm,
to show us something, they took us outside and we went and looked at something. And
mhm,
honest to God, that was probably the day I learned the most. And I remember the most because when the question came up on the test, I could visualize what we were looking at outside. So we talk about kinesthetic learning through movement. I have
Absolutely.
had a brain injury. I'm not going to call him a child now. He'll probably say to me, "Why are you calling me a child? He's 17 years old." I've had the pleasure of working with him for a while, but he loved basketball. So you know what we did? We got the rehab assistant to do his questions of homework while he was shooting basketballs.
mhm,
And there's also evidence around this that when you're moving, you can learn. When you're walking, you can remember things because there's a rhythm to your body and to your brain. So I have learned, Remy, that we shouldn't just go now into one sense. We need to look at all the I'm actually using sensory, the smell, a lot
Mm.
more with brain injury in the last few years because I think it's an under-tapped way of getting people to remember. Think of yourselves, and when there's a smell that comes from your childhood, all of a sudden this flood of memories comes back into your brain, and you can do that again. You can replicate that again by encoding memories associated with different smells. It's fascinating, the things that we can learn. And the beauty, again, Faith and I, as OTs, have the flexibility and the luxury of pulling all these different strategies and trying them if the
mhm.
client agrees. And there's nothing wrong with trying it. And what's the harm? Of course, her and I are looking at risk versus harm all the time. If there's no harm, we try it. If it works, great. If it didn't, we move on to a different strategy.
And teaching, we call that multiple intelligences. When we're trying to engage in, and certainly I've used it in my career many times to make sure that things, and it was, for some the social works, for some it's the kinesthetic, some the kinesthetic gets in the way. They'd rather see the visual or they'd rather hear it. But again, trying as many different sensory inputs as you can. And I see that in BIAR as well. When we incorporate in our programs, we have music therapy, we have art therapy, we have mindfulness, we have archery, we have rock climbing, we have everything. Things that retrain the brain, not necessarily in things like bathing and eating and things like that, but definitely hopefully rewiring it and appealing to as many of those different senses and those different modalities as possible. Now, Taz, you mentioned you had a client that you've had for a while that you've known for since they were little, and now they're what, 17. You don't want to call them a kid anymore, but I think you also mentioned to me earlier that you have a client that your oldest client was 102 that you've worked with. So I think I'm going to ask this question of you. How do you account for your clients aging as you go through the process with them?
So I have to tell you something. Sometimes life also teaches you lessons. So I have had the pleasure and the honor of having two elderly parents that I've lived with, cared for, and then have subsequently passed. So I've learned some life lessons in my last 20 years of life. And that is, first of all, never underestimate age. Age is really a number. And I have seen some much older people do some fascinating things. And the second thing that I've learned, although you didn't ask me directly this, but I'm going to tell you, is ageism is alive and well in our system. And I have had to advocate really hard for older clients. And I am saddened sometimes by the response that I get. During COVID, I had a gentleman who was in his 80s who was struck by a car, had a previous stroke, so he already was somewhat impaired before, but really active overall, really highly engaging, social, was involved in his local mosque, was hospitalized during COVID for a long period of time. And the hospital refused to apply him for a fast track rehab. Faith and I know there's different levels of rehab that people get put into, that get applied for, and they wanted to put him into low stream. And I was like, why aren't we giving this guy a shot? It took Remy months of me and other team members and the family. And this man finally got into ABI rehab downtown at UHN. I was so happy. But the effort it took, that how many people are fortunate to have advocates? And oftentimes, Faith and I see this. It's still sometimes the have and the have-nots. And if you've got an OT and you've got a case manager, if you've got somebody to help you and advocate in your family, great. But what about everybody else out there who doesn't have that? Our system should not be set up in a way that we need to have someone advocate all the time. But it's the truth. And so sometimes what we can do, Remy, is also educate, like you're saying, educate. I can use my experience as an OT. I can use my experience as a daughter. This week, I talked to two friends who have palliative parents. One just passed away. And I was talking to her on the phone saying, ask them for this, because if we don't give that information to someone else, how are they going to learn? How are they going to know when to push the buttons in a system that is already overloaded? So I may have gone left with that, but I had to say that because it's sort of been a pet peeve of mine with elderly clients, especially brain injured clients. Some of them have done the best recovery, Remy. I've seen some of them have the best recovery because of the human will and just this whole attitude. There's an age group about 75 and over that just have this attitude. You know what? I can do it. Leave me alone right now. I can do it. This fierce stubbornness and this fierce independence. And it might be really irritating at times for family members, but I like to work with those people. I really enjoy it.
But as you see them, if you start with a client that, again, both you and Faith, you work sometimes with clients for years and years and years, and you see them get older, your intervention changes as they go through each transition. So you would reevaluate each time and decide. Do you find the system also tends to have a bias against people with more severe brain injuries? Is it less severe brain injuries? Is there any the way that you find the system mistreats any other aspect of brain injured survivors?
I think,
I'm going to say yes, but I'm going to let Faith answer.
unfortunately, I think our system, there's a lot that can fall through the cracks in our system, especially if we're talking about acquired brain injury and we're thinking about those injuries that come from motor vehicle collisions or other sorts of traumatic events. When an individual goes to a trauma center, I also worked in the emergency department of a trauma center for 3 years, and so I've been able to see this firsthand. But the focus is very physical, rightly so, because everyone there is in life-saving mode. And so we need to make sure that this person stays alive. And so the focus is very focused on physical injuries, on orthopedic injuries. They're going for their MRIs, they're going for their CT scans. So individuals are in the emergency room, they're headed up to the ICU, they're going to the ward, and they're going through a lot. There's been a big change in their life. They're dealing with a lot of injuries. They're learning a lot of new information. They're on a lot of medication, which is impacting their thinking skills. they're in an environment where they're not getting adequate sleep. They're being woken up to be given medication. They're woken up by their roommates. They're woken up by the beepings and the announcements in the hospital. So they're not getting a good sleep at night. They're in an unfamiliar environment. There are so many things in that environment that are impacting their cognition and their mood that if their cognition or mood is different from their baseline, there often isn't a red flag because there are so many other factors that are impacting it that it's often attributed to all of these other factors. And often what happens is then these individuals go home and then the community OTs get called in and we go in to see them. And at that point, they are shocked, confused, bewildered why they are having a hard time with getting dressed in the morning, with getting back to work, with making their kids lunches. Why can't I do these things? And it can feel maybe too late because now they're out of the hospital and they didn't think to, or they hadn't noticed to raise these concerns while they're in the hospital. And now they're really struggling with their cognitive and their behavioral changes. And they don't have the follow up with the head injury clinic at the hospital because this wasn't identified then. And so if you don't have that occupational therapist, that caregiver, or another rehab support worker who's there to advocate for you and get you that follow up and get you the care that you need at that time, it's really easy to fall through the cracks in the system that we have, unfortunately.
I've heard that mentioned quite a bit, that once a person leaves the hospital setting, you're on your own. If you're lucky enough to have an occupational therapist, or even better, a case manager, you're in a much better situation. But I've met survivors who it's just them. They got lots of care when they were in the hospital, and then they got home and realized, oh my goodness, it wasn't just the trauma of the accident. I have some other stuff going on here. And certainly our system needs to step up for that. I was speaking with, again, a case manager and saying that it's too bad that case managers are only assigned in the cases of catastrophic injuries. I think you'd agree that you need one for all cases. Our case manager, we didn't have one because my wife wasn't catastrophic, was our OT. That was the person who got us through a lot of things. And so I guess that's your other hat, is dealing sometimes with the system.
I am going to say something positive about, because we are part, as BIAR, we are also part of the stroke network in York Region with Mackenzie Health. I have to tell you that the stroke program, from what I'm hearing, even from clients, from community members, and inside what we get is the information, is the stroke program seems to be doing a really good job. So they are getting follow-ups, they are getting supports, as long as they're in the system and they've been identified. I think we're coming to a place right now where stroke is actually being treated in a very multidisciplinary, a very good way. This is what I'm seeing. There are other aspects of brain injury that definitely have their negatives in the community. But I tell family members that we got to work with the system we have right now, unfortunately, and this is the system we have. And then again, like we said, is finding advocates is really important. And it doesn't have to be an OT, right? I tell somebody, do you have a family member who's a nurse? Do you have somebody in the because sometimes it's cost prohibitive. People don't have the money to hire someone. And in that situation, I ask them, is there anybody else in your family? Yeah, my uncle is a pharmacist. Great. Can you talk to your uncle? Because he's going to know what to do in this situation. And maybe it's assigning that role to someone else in the family who can take it on, who can help
So
them.
you find as an occupational therapist, those are the important questions to ask. And in other words, those in essence, they are caregivers as well. They may not be living on site, but they're helping out. So at times you find yourself working with caregivers to help them negotiate that system, or this is the need that's there. Can you help out with this? Or do you ask the survivors to take care of that, or both?
All the time I'm talking to the caregivers, all the time, because they become part of the system. And so as long as the client is consenting, I have to be honest, I talk a lot to caregivers. I do. And a lot of the times it's because sometimes I've had a conversation of instruction and then the client knows, but I need to reiterate that instruction back to the caregiver. Or we came out of a medical meeting and now I need to ensure that the client understands. And sometimes it's overwhelming. right? But then I need to ensure, did the caregiver understand what came out of that meeting? Because sometimes you walk out of there and it's like everyone's exhausted, everyone's feeling overwhelmed. And Remy, I see you nodding and you know this. And so sometimes it's too much. And so I need to go back and ask.
Not everybody's caregiver. And if you have a stroke or you're some type of ABI, it's great if your caregiver happens to be pretty familiar, very good at note taking, is highly organized, is used to dealing with insurance companies and medical professionals and understands a lot of the terms. But not everyone has that. A caregiver, the way we qualify for this role, I think I've said this before in other interviews, is we care about the person who had the brain injury. That's our qualifications. We are the least qualified member of the rehab team, and yet we're the one that's on site 24/7. And that's one of the reasons why I started this podcast, is that it's a constant education for us. It's a constant checking with professionals like yourself saying, what just happened? I know I'm supposed to keep track of all this, but I don't understand any of this. And so you find yourself educating caregivers. Do you also find yourself working with caregivers who express, for example, things like compassion fatigue or burnout?
Like I said to you, when I was a caregiver, I have such different empathy now for caregivers. Being in a caregiver situation and feeling that exhaustion and the lack of sleep and the worry and feeling like my brain is not functioning and anxious. I just felt anxious. Compassion fatigue is something really important for people to understand, because it is what prevents caregivers from actually asking for help, because there's also a component of guilt that is going on. Should I be feeling this way? What right do I have to feel this way? And that sometimes starts to play a big dynamic in it. And then they start to not look at their needs as a person, as mental health and health. I have had a couple of caregivers who have not told us about their heart pain, the chest pain that they've been having for the last 2 days. And I kid you not, today I had a conversation with a client and I said to her, I've given you a lifeline. I know you know how to use it, but the lifeline is not just for you. I don't prescribe lifelines for just the client. It's if something happened to the caregiver. So if the caregiver, God forbid, has a heart attack or faints and passes out, how does who this person is not able to move is able to get help? Call the lifeline, press the lifeline and call for help for that person. They'll call 911. They'll do it immediately. So I'm constantly thinking about the full circle, the full plan, because the person who's in there, Kate said, the person who's critical, who's taking care of that person, what if something happened to them? And that is our responsibility, by the way, because my responsibility is the care of the client. And if the person who's caring for the client is something happens to them, I need to have a backup plan.
So if you find that, for example, a caregiver is overstressing themselves, they're not getting sleep, they're not eating properly, or they're in any way neglecting themselves, you step in and perhaps have a conversation with them. How does that happen? Maybe go into a little bit of detail there.
I definitely, so today it was interesting because when I was talking to the wife, who's the client, the husband wasn't there. I have a very good relationship with him, but I actually sat down and looked at her and I said, how is he doing? That was part of my questioning. And she said to me, he's sleeping near her and he doesn't want to sleep away from her. But the problem is he's sleeping on an air mattress right now in the basement. It's not a great setup. He's not sleeping and he's got back problems. So I walked away from that and I said to her, would you mind if I talked to him? And she said, would you please? Because he's having, I think there's some of that guilt going on. My wife went through all of this. She's been alone all this time in the hospital. She's just come home and I don't want to leave her. And she said to me, I'm okay if he goes upstairs for a couple of nights in the week. Maybe he just goes upstairs. So this is a conversation I will now have with him and talk to him about what do you want to do, but I'm not going to push. So if he says to me right now, Taz, I want to stay near her. And then what I did is I said, can we revisit it again in 2 weeks? And he said, sure. So you kind of have to meet them where they are emotionally, but I just let him know too that I do care about him. I'm looking at him too. I'm treating his wife, but to me, he's part of the system. He's part of her care network, and I need to make sure it's healthy.
Caregivers are 100% a part of the circle of care of the individual. And I think I experience a lot. Sometimes I can feel like a liaison between the client and the caregiver. I'm working with the client, and the client is expressing concern for the caregiver. They're expressing guilt that Taz has mentioned. They're expressing feeling like a burden, and they don't want to say this to their caregiver. And caregiver may be in the home, and then the session ends and the caregiver says, "Oh, I'll just walk you out, make sure you get to the car." And then they're crying in the driveway and they're just unloading, and they don't want to say this to their loved one. And so a lot of times it's you're getting both sides, and how do you bridge this communication? But also another point that I want to bring up is we just talked about who is falling through the cracks. Caregivers are falling through the cracks. Caregivers are the ones that there is such a significant lack of funding for, because these individuals are so unbelievably burnt out from working. Some are working their full-time jobs and then coming home to a second full-time job. And yes, that compassion fatigue. And of course, they are going above and beyond for their loved ones, because who wouldn't? But as said, they're diminishing their own well-being for the sake of their loved one. And ultimately, that can harm both of them. But they are the ones who the funding is not available, the support is not available to the caregivers. And ultimately, they're the ones that are going to be and are falling through the cracks.
If you had one bit of advice for caregivers when you first meet them, and regardless of what the brain injury is, what would it be? They've been thrust into this role. They're often not sure what to do. They think they're doing the right thing. They're hoping they're doing the right thing. And they're really looking for information, and you're a great source for it. So again, I'd like to ask you, what if you had one piece of advice, or maybe two, to give caregivers, what would it be? Taz?
So I'm going to say that they absolutely need to learn how to accept help. So the caregiver themselves needs to be enabled to accept care. And what I mean by that is, even though the system out there is not built for caregivers, and I'm talking about even the economic system is not built for caregivers. People have private benefits that some companies will pay for being off on caregiving leave, and then you'll have another worker who will have absolutely zero. And then you'll have people like myself who are self-employed and have nothing, right? So we're all in these different places economically. But I'm going to go back to saying the community itself can be a significant part of that. So people who are part of any group, and it could be a religious group, it could be a church, it could be a mosque, it could be a temple, it could be a synagogue. These are significant places of getting support. But the person has to be able to accept that help. Now, if you don't have those, then your friends network, your family network, people ask, they will often ask, what do you need? And you know why people are asking that question? Because they really want to do something and they don't know what to do. And this is often seen at the time of people when there's death in the family and somebody says, I have enough casseroles in my fridge. But why? Because they actually wanted to give something and this is how they're doing it. So you know what, if someone asks, how can I help? Tell them, are you available to drive? Maybe my spouse needs, there's a medical appointment and I can't be there. Are you able to go with them? You know what? They'll say no if they can't. But if they say yes, Remy, that's the start of a beautiful relationship. Because now there's somebody else helping. And that person, by the way, is going to feel really good helping, because there's something about dopamine in our brains that we all want hits of dopamine, and that happens when we help each other. So I tell people, sometimes your pride gets in the way. And if you want to be a caregiver, and Remy, I think you're probably the right person to ask this to, is getting help not such a bad thing?
It is, absolutely. And one of the things that I've noticed, though, among caregivers is there is a strong reluctance to seek help. And there's a bunch of reasons why. Probably the most important one that I can think of is that this survivor, the person with the brain injury, becomes your whole life. You know them. You're not a medical professional, but you certainly know them probably better than anyone else. And it's very difficult to step back. I think of those medical dramas when they push people out of the ER room. They push the husband or the wife out while they're working on this cardiac stroke or whatever it is, this bullet wound, and they push them out because those people want to be there. They don't want to leave, even though they're not the best qualified, or even though they're burnt out or they can't do it anymore and they really need the help. It's very difficult to step back. And again, I think you hit the nail on the head there for the second reason is you don't want to burden someone else, particularly if they're not a health professional. I have no trouble as a caregiver. I get a OT, you're getting paid, you got the training, you know what you're doing. Here you go, right? I don't think I'm the type of caregiver that would fall into the role. Well, I know more than the OT because I know my wife. But when it comes to, for example, asking family members or friends or that type of thing, even though they may be great, they're wonderful people, we know the burden. We know what the burden is, and we know just how high it can be, even with comparatively mild brain injuries. Certainly, with people looking after someone with a catastrophic brain injury, it's even more. So it's a lot to ask. So I guess as OTs, I'm very long-winded, you basically have to reassure the caregivers that it's okay to ask for help. Would you agree, Faith?
Absolutely. The age-old comparison is you're on a plane, they tell you to put your own oxygen mask on before someone else's. We all know that logically to some degree, but I understand that it can be really hard to practice that in the moment. But if you're a caregiver, your loved one needs you and they need you at your best. And you can only be at your best if you're prioritizing your own well-being. I would want to tell caregivers that you are a whole person too, and you are a whole person with needs as well. And you are about to enter this world where all of the spotlight and the attention and the care and the focus, including your own, is about to be on your loved ones. And I know that you are likely the first one to sign up to take that position, but it's draining and it's exhausting. And so you need to come back and remember to put your own oxygen mask on, to fill your own cup, because that is the state that your loved one needs you to be in.
Can I
Go ahead.
say, I just want to, because you keep talking so highly of OTs, and first of all, I want to say thank you because it's nice to hear that. So I'm just going to be honest, but there is something that Faith and I experienced that I don't know how many other health professionals get to experience it. We go into people's homes.
Mhm.
So we are the therapists that are in the homes. We sit down, I'm offered meals. We are offered tea, and we sit down with this family and we literally can break bread. There is a part of this dynamic where I'm not saying I'm part of the family, but I do feel very close to the bond. There's close bonds with this family, but there's a distinction in the fact that I'm still there. But so that means that if I have that connection with them and if I have the trust, I'm able to tell them the truth. And sometimes you need people to tell you the truth, and it can't be a family member. So we are the ones who can turn around and say, look, I get it. I get you want to keep giving the care, but right now, you don't look so good. You don't look like you're getting enough sleep. And sometimes for a caregiver to just hear that, it's just somebody now looking at them and saying, listen, I see you. I see what you're doing, but I'm a health professional telling you that you yourself need help. And again, not so easy, right? Because if it's a mother caring for a child, what is she going to do? Step out of that position? No. But we can try to do our best to engage other people. Or I'm going to do a plug for BIAR right here. Why did we start caregiver services, Remy? Because we wanted people to have another space for caregivers to come and have some more supports. So they're out there. Could we perhaps offload somebody for 60 minutes or something to join a support group? Maybe that's what they want. And if that's not what they want, maybe they just want to go take a shower, honestly. So can someone step in for 30 minutes to help that person just do what they need to do during the day? And that can become a really strong point of our job.
Oh my gosh, it can be so vulnerable for the clients and the caregivers. And I think we develop a unique connection with clients that we're working in the home with compared to when they're going in clinic or having virtual services. It is a very unique connection, and it does give us an opportunity to observe more of the family dynamic, the caregiver dynamic, the home dynamic, and it builds more trust both ways. And yes, absolutely allows us to provide the truth that can be hard to provide sometimes. And when it needs to be provided by a trusted professional, I absolutely agree.
Finally, I'm talking with Ellen Lipkus, who's been an OT for 36 years. 26 of those have been with Rehabilitation Management, Inc. Her current focus is on future cost of care, where she usually interviews family members to review pre- and post-injury changes. Welcome as well, Ellen.
Thank you for having me.
What do you see as some of the most common cognitive and behavioral changes in patients with brain injuries?
So each client I work with is unique, and we have to take their environmental situation into consideration. So, and how it's impacting them. But quite typically, we see issues with things like memory, their ability to focus and concentrate. The idea of making decisions can be overwhelming, and each one impacts the other. If you can't focus and concentrate, then you can't remember because you're not giving it whatever it is you're attending to your full attention. So they all interplay with one another. And then the behaviors can also be partially related to the brain injury and partially a secondary consequence of difficulties, cognitive challenges, like the frustration that goes along with that. And then struggling to communicate how you're feeling can lead to more behavioral challenges, impulsivity, and how that can impact your mood and how you adjust to changes in your so-called new normal. So there are so many factors, and each one is impacting on the other.
You mentioned some of the behavioral changes that might occur. Often I've talked to caregivers who can be quite frustrated in their role as a caregiver dealing with behaviors. That is a big source of stress that they talk about. How do you assist with that? Is there some counseling you give to them? In your experience, is there a better way to deal with a survivor of brain injury whose behavior changes either because of physiological or because of the trauma reasons?
So in my role in doing future cost of care, I don't have an ongoing relationship with my clients. It usually spans over 2 or 3 months. But over those 2 or 3 months, I spend a lot of time gathering information and understanding where their difficulties are. So I will provide some education. I'll certainly make sure that they understand the roles of each of the different service providers working with them. But from an OT point of view, I often have them make up a sort of cheat sheet. What are the problems? What's working and what's not? What strategies do you use when your loved one gets upset? What do they tell you they want you to do to help them? Because that's a really important point. If your loved one is upset about something, finding out, how can I help you? What is it that I can do that can assist? And then write it down somewhere, because in the heat of the moment, nobody can think clearly. So if your loved one is upset or frustrated over a certain situation, hopefully that little cheat sheet that you can look at or remember, reference, is going to remind you of a strategy that was successful. And maybe it's taking some time with your loved one outside of the moment to say, yesterday you were upset. Let's talk about it, and let's talk how I could help you. What could I have done differently? And then come up with those strategies that each one of you can use, because the individual with the brain injury needs to be able to assist as well and needs to be a part of the process. So really, I want to empower the caregivers and the individual to problem solve the situations.
So you did mention that your role is a little bit different than Faith and Taz. Could you describe exactly what you mean by establishing future cost of care?
Yeah, that's a great question. So we call it a life care plan, or future cost of care assessment is an assessment that I spend the time understanding what the individual's life was like prior to their injury or loss, and then identifying how they're functioning now. So I could have missed the first 5 years post-injury. I'm often coming in years after, when you're looking at it, we know what their maximum potential is going to be. We know what that so-called medical prognosis is. and then identifying what their future care needs are. All of the professional services, all of the caregiver, attendant care, so-called services, even equipment services. I'm going to consider the different transitions. So if I'm doing an assessment on an individual that is 15, injured when they were 8, I have a lot of life planning to do, a lot of transitions to do. And so my plan will look different for them, and there will be things that I'm going to need to consider for them that's going to look different than the person that I'm assessing who maybe is in their mid-50s, injured 5 years ago. They still have transitions, but I want to understand what they're going to be, what their goals are, and then make the recommendations. I often then say to my clients, you will get my report, put it in a drawer somewhere in your house. And then when you hit that transition or you hit that problem, pull it out. And I hope I've anticipated it. And my report is going to tell you what services that you need to put into place to help. And it'll also identify what I believe the individual's potential is. What are the functional gains that I anticipate if they could have access to treatment? Often, if I'm unsure about something, I will do 2 scenarios in my plan.
Oh, okay.
So plan A, scenario 1, should this happen, these are the services I recommend. Scenario B, if you take a different path, let's say you don't go back to your old job and you're going to look at something else. Well, then I'm going to give you the services, the recommendations that I think you're going to need, should that be the path you take. And if going back to employment isn't an option, I'm going to give you another option, because everybody has a right to be productive and engaged in meaningful activities. But the main point of the plan is that I have to listen to my clients. What were your goals pre-injury? We're going to likely have to adjust those, but what are they now? What are the realistic goals for them now? And that's what I want to work with, because it's their life. It's their values, it's their goals, it's not mine.
What actual costs? What about finances? If you, in your plan, you must take into account whether there is the money to pay for a lot of this stuff.
So, I get to work in a different world than people working in the accident benefits motor vehicle. I'm not restrained by cost, in the sense that I'm identifying what I believe their future care needs are, and then it is up to people that are doing different roles to figure that piece out. But my job is to make sure it's reasonable. I'm identifying the reasonable recommendations that they're going to need. Often the people that I'm working with are involved in some sort of legal case, and that's where they're using my information. I do also try to provide education on what services are out there that are free. What are the places like BIAR? I make sure I'm giving that education to the clients. Are you aware of these associations? Are you aware of these links online, these free webinars, so that they know what they can access that isn't going to have a cost associated?
If someone is involved in legal action, they will take your report and say, oh, this is what the OT says that the next 20 years or however many years is going to cost for this individual. This has to be factored into any settlement. Am I correct there?
Yes.
How did you decide to get into this particular focus, the future cost of care? What made you choose this particular field in occupational therapy?
That's a good one. I often ask myself that question. So when I started at RMI, I was mostly doing occupational therapy, like active OT and case management. And then I got asked to do one future cost, and it just snowballed. And that just seems to be what I'm asked to do the most. I've created a bit of a niche for myself in completing the life care plans. It just evolved.
Assistive devices, you take into account those. Again, you would have to, I guess, look at the survivors and the caregiver's ability to operate the assistive devices. Do you help out with that, or how does that come in?
Yeah, so absolutely. So I have to consider the individual at the moment in time that I'm assessing them, but then they're aging with their injury. So their balance may be great now at the age of 30, but what's it going to be like when they're 55? And individuals don't often come just with a brain injury. They often come with some sort of orthopedic injury. It could be as well, right? Or they have pre-existing other medical concerns that are not even related to their brain injury. They could have other health conditions. I have to consider those as well. So I will, and then I'll educate them on, I always review my plans to make sure that my clients are on board with my recommendations. I'll let them know the idea of what devices I think they're going to require as they age, but then I'm going to recommend the occupational therapy that goes along with it. And I'll write that in the report. I recommend these assistive devices, and I've included occupational therapy intervention in order to put them in place and provide education.
Okay. And you do take into account the caregivers in that role when you're recommending devices. And the information for this, you mentioned that a lot of this comes from the medical report, the neurological report, and other sources, but do you also go into the home and meet with the client in the home to see what would be appropriate for where they're living and their lifestyle?
Yes, so I do review all the medical documentation. If there are treating people already in place, I'm going to speak to them to find out what they've been working on. Understand, how has OT been beneficial? What are you working on? What does that OT envision for you in the future? Because I want my clients to understand what the people that they're already working with have, what their goals are for them, what their ideas are. I will speak to, all of my assessments are done in the home. They're not done, well, some of them can be done virtually, but I am meeting with the clients in their home environment because I want to see where they're functioning. And I want to understand that. And I spend time with whoever they've given me consent to speak with. Often it is a caregiver, whether that's a partner, a child, like a daughter or a son who is adult age, a sibling, whoever it is, because I really want to gather information about what my client was like before their loss and understand what they see the person's difficulties are now, because insight can be a problem when you have a brain injury. And often the individual doesn't recognize all the help and support that they are getting from their caregivers. So spending some time with those individuals that are providing the care is really important and does give me insight into all of the impairments.
Do you find on occasion that caregivers are a little too eager to volunteer information that you really want to hear from the survivor? You have to say, oh, you really know the person, thank you very much, but I'd like to hear from her or him for their answer.
Yes, it does happen, but I do make it very clear. I hope at the beginning, I want this part of this is with the individual, but I am going to spend individual time with you. So do not worry. And I let them know that it's a process, that I'm in the house for several hours, but that's not the end of it. I will touch base with you while I'm going through the process of writing my report because there will be more questions. But don't feel that if you've forgotten something, that's the last chance you have to speak with me. Reach out to me. I am there. Call me, email me, because it can be overwhelming and stressful to try and think of everything that you want to say in the moment. So knowing that you have that time, they will have alone time with me, and over several sessions does help everybody relax through the process.
Do you find that a lot of caregivers are stressed out, burnt out, even at the point that you meet them? Is there any way that you're able to help them at that point? If you had a tip, and I asked this of Faith and Taz as well, if you had a tip for caregivers when you first meet them, one piece of advice, what would it be?
I think it would be make that list, have your own cheat sheet of what are those things that are really important for you to continue to do, your so-called self-care things, whatever they are, and talk to them, talk to your loved one about them. They need to understand too. They're in it with you. You're not in it alone. And I think that getting almost that mutual respect and trying to help the individual understand that your caregiver has needs as well is really important. Make that list of people in your life that are there to help and call on them to help. Don't try to do it yourself because they say you have to take care of yourself so that you can take care of others.
Do you find that caregivers are often reluctant to do that, to seek help from family members or friends or whomever?
I think sometimes it's a little bit of afraid to let go of some control, right? Afraid of what will happen or afraid of letting go of that control. Or I think you get a little bit on that spinning wheel and it's hard to jump off the wheel. Even as the individuals gain some independence, if you've been helping them with a task all the way along and all of a sudden the individual likely can do it on their own, you don't always see it as a caregiver. And so sometimes it is stepping back a little bit. And I often find that when I am in doing an assessment and I ask, what is the client doing to help out around the house? And they go, well, not really anything. And they hadn't even stopped to think about it. And I go, well, why aren't they helping you fold laundry? They can fold laundry. You know what? You're right. They can fold laundry. But nobody takes a moment to step back. And also, I think flexibility, right? Which is so hard for us to be flexible all around. If it was always the role of the caregiver to do all the cooking and the cleaning because the individual that is the loss was out doing other things, well, life has changed. So maybe as the caregiver, you're going to have to give up something that you used to do. It's okay to give up that control. If all of a sudden the individual is able to help with laundry because that's a task within their physical abilities, maybe you step back and stop doing laundry. They may not fold the items as nice as you do, but that's okay. And that I think is really hard for caregivers, right? If it's not done the way it used to be done, or it's not done the way you like it to be done, you have to learn to let it go, because at least we want the individual to be productive and doing things, even if what they're doing is different than what they did before.
Do you find that that's sometimes the reverse as well? That because I've heard from survivors that they often, if the caregiver is not the one traditionally doing the laundry or the cooking, and it's the survivor that has been doing it and cannot do a lot of that anymore, that they have certain standards, they have certain ways that, and it's difficult for them to let go of that and allow the caregiver to do it. And when the caregiver does it, it's not done right. You see sometimes that kind of conflict.
Flexibility and adjusting to change is really challenging all the way around. And I think it's a process. You can't do it all at once, and you have to prioritize and find out what's important and work with your team to identify everybody's goals. What, as the caregiver, can you give up? What is still too important to you that you're not going to give up? And what are the goals of the individual with the injury? What roles are they willing to assume that maybe they didn't have before? Because that's an adjustment in its own right as well. So flexibility is really important all the way around, and giving yourselves permission to take the time and to prioritize. Understanding, like I said, it can't all be done at once.
Now, I know now that you initially meet with clients at the very beginning, and so you're not necessarily contacting them years and years in. But before you did the focus that you do now, did you notice that and you went into the home and you followed clients for sometimes years? Did you notice that there were different transitions, different things, different dynamics going on that you had to adjust for? Different stages in the recovery that you hadn't anticipated, and that you had to deal with?
Right. So in my role now, I miss the very beginning, right? I come in 4 or 5 years later. But when I worked as or
Yes.
even as a case manager, yes, I was coming in right at the beginning and following them for many years. And rehab is always changing, right? Goals needed to be adjusted, rehab plans needed to be reviewed, priorities needed to be changed. And plus, after a loss, sometimes the individual's priorities change. So what they felt was important before their injury, they still think is important immediately after, but sometimes that changes. It can change 6 months post-injury. It can change sometimes 2 years post-injury, where they say, I thought that running the marathon was the most important thing I had to do pre-injury, and that's what my goal was. But I see now that's not as important anymore. This is my new goal. And so it is something that has to be discussed all the way through rehab and looking at. As a case manager, I would do that regularly with my clients.
It's funny you should mention case manager, because I think Faith had been a case manager at one point, no longer concentrates on that. And I thought when I first met our occupational therapist, I thought case manager and occupational therapist were the same job. Is that accurate, or is it often that they take on each other's roles, or does a person always need a case manager if they have an occupational therapist?
So they are two very different roles, but OTs are often case managers just because of our training, that we take the cognitive, the physical, and the emotional into consideration. We are skilled to address all of them, and look at the big picture. As a case manager, you're overseeing all of the services and making sure that the rehab plan is working on the client's goals or adjusting it as you go along. The OT is really just working on their one little piece of function and helping the person get back to their roles and responsibilities. The case manager is coordinating it all. So the OT may call up the case manager and say, we really need a rehab support worker to implement my plan. Can you make the referral? Find the right person, interview them, get them on board. Or we need a medical specialist. We need a neuropsychologist on the file. No problem. As the case manager, you're going to coordinate it. Make sure each service provider has all the information they need. And make sure that there's collaboration. As an OT, I don't want to work in isolation of the psychologist, because knowing what strategies help to manage behaviors and emotions, I need to know that as an OT so that when I'm engaging my client in an activity, I know the strategies that I can cue them to use. Rehab can't work in isolation.
So how much is it you contacting the other members of the rehab team, or you simply ask the survivor or the caregiver to relate what, for example, the neuropsychologist has recommended or the physiatrist or whoever else? How do you communicate with other members of the team?
I call. If I'm an OT on a file and I'm talking to the client and they're giving me some information, I'm going to say, I need to speak to your psychologist. I think it would be great. We could do a joint session. Could I step in and talk about how maybe your mood and your lack of motivation or your irritability is impacting your ability to get back to cooking, and cooking is your real goal? Let's do a joint session so that they can help me in developing that plan to get you back to cooking. You have to treat the person as a whole. And as OTs, that's what we are specialists at doing, looking at the big picture and treating as a whole. And then the case manager may be a part of it, and you may have a team meeting. You may have an idea where everybody gets together.
And there are times when, depending on the injury, they're simply not assigned a case manager. There just isn't a case manager in the picture.
No.
That was our case. We did not have a case manager.
Right. But as an hopefully, even if there's no case manager, often OTs assume a little bit of that role because we know what needs to be done. But I very often will reach out to the physios that I'm working with on a file, the psychologist, because mobility has a significant impact on function. And I'm looking at function. So I want to know what the physio is doing.
Would you say it's accurate? I've heard it said that occupational therapist is almost a misnomer because people often don't understand. They think occupation, it must be something to do with getting back to work, and it's all about work. It's not about living. Would you agree, as it has sometimes been said, that a more accurate description would be almost a life coach or a life therapist?
No, that is great. It's a really important point. Occupation is anything that you need to do or want to do. It could be your self-care, it could be your leisure, recreational, it could be the roles that you fulfill, mom, dad, son, daughter, sibling, friend, all those roles that we do in our everyday life. And then work can be anything from paid work, it could be volunteer work. It can be, as a student, your work is your school. So occupation is anything we really want to do or need to do in our everyday life.
Do you find that sometimes as Taz and Faith have mentioned, that the system needs to really improve in terms of how much OTs are able to do, where they need to be assigned? There need to be more of them and involved earlier in patient care. Would you agree with that statement?
Oh, yes. Everybody can benefit from OT. Everybody, injury or no injury, because our insights into pacing and prioritizing and lifestyle and balance really are critical, right? That's why we work with all sorts of problems, anxiety, depression, anything, because anything that impacts your ability to function, an OT can have an impact. If they got OTs involved at the get-go, the very early stages for people, I think people who with more acute injuries that come in and out of hospital, they wouldn't be going back in because those safety issues and all those concerns and those risks that cause secondary injuries wouldn't be happening if an OT could just get their eyes on and the education in place.
So, Ellen, would you agree that if they hired more OTs, and a lot of the times the objection to hiring OTs is financial, but it actually, if you're saving future from people from future hospital visits, you're not only saving money, you're also saving people's stress and suffering by being proactive rather than reactive.
Absolutely. And I think it also helps the caregivers. If an OT could get themselves in the door at the very beginning and identify some of the risks or help in ensuring the individual's safety, it would reduce the stress and the strain on the caregivers as well.
Again, like many on the team, you work with the whole family. You work with the caregiver, you work with the survivor, you work with other members of the team, but you're there to really get to know the family, to really work to understand what their needs are and how they change over time. So it's definitely, I can understand it's a firm commitment. No one becomes an OT to make the big bucks. You're doing this because you really care about your clients. And I see that in talking to you. And I can tell you as a caregiver, and I think I can speak for a lot of caregivers, we really do appreciate our occupational therapists. And I'm hoping that they get a lot out of this interview. Thank you, Faith, and thank you, Taz and Ellen, for all of your help and all of your amazing comments. And I hope to talk to you soon since you're on the board of BIAR as well. And that also shows your extra commitment. We'll maybe talk about this again soon. All right. Thanks very much.
Been a pleasure. I'm so happy to have joined. And I want to say congratulations again on a wonderful podcast season, your first one, inaugural.
Thank you,
Yes.
Taz. This is the final one of the season. All right.
Bye.